the worldwide. In 2021, there were about 537 million people with the diabetes in the world, and the numbers are projected to 783 million by the year 2045. So that shows that every year the diabetic population is increasing in the world in general and in India in particular. In the world, about 90% of the type 2 diabetes, whereas in India, nearly 94 to 95% of the type 2 diabetes. And if you see the burden of the diabetes in India, in 2023, we are having about 101 millions, that is 10.1 crores of the Indians are having the type 2 diabetes, and 136 millions, that is 13.6 crores, are having the pre-diabetes. So if you combine the diabetes and the pre-diabetes, the dysglycemic people are to the tune of nearly 25 crores. And diabetes has no boundaries. It is common in almost all the states of the India. And if you see the South India, North India, West India, and Central India, Andhra Pradesh and Telangana are having the prevalence nearly 7.5 to 9.9, whereas the other southern states like Karnataka, Pondicherry, Tamil Nadu, Kerala, they are having the more than the 10% prevalence of the diabetes. If you see the fasting blood sugar, the normal fasting blood sugar is less than the 100, and the diabetic range is more than the 126. And if the fasting blood sugar is between 101 to 125, we consider them as the pre-diabetic or impaired fasting glucose. In the same way, the postprandial blood sugar or the 2 hours OGDT blood sugar, if it is less than 140, the normal individuals, and more than the 200, diabetic individuals. So the postprandial or the 2 hours postprandial blood sugars, if it is between 141 to 199, we consider them as the pre-diabetic individuals. So these pre-diabetics are very, very high in number in Indian population, maybe because of the childhood obesity, maybe because of the inactivity or the environmental factors like urbanization or localization or motorization. And mostly it is associated with the high calorie diet intake with the very, very, very minimal physical activity occurring in the new Indian population. So these pre-diabetics, because of their unawareness or maybe because of their ignorance, a lot of the people, the diabetes has no boundaries. In most states, the prevalence of the diabetes and the pre-diabetes is to the tune of more than the 5%. And if you see the different states in India, South India, especially the Karnataka, Tamil Nadu, Pondicherry, Kerala and Goa, Maharashtra, and also the Chhattisgarh, or Punjab, Haryana, Delhi, these are all having the high incidence of the diabetes prevalence more than the 10%. And in Andhra Pradesh and the Telangana and Orissa, so the prevalence is between 7.5 to 10%. See the burden of uncontrolled diabetes in India. So having said that, nearly the 25 crores of Indians are having the dysglycemia, and a lot of the people with diabetes, they are not under control. So the controlled diabetes means the fasting around 100, the postprandial around 140, and the HbA1c around 6.5. And hardly 16.3% of the people are having the HbA1c less than the 7%, whereas 83.7% are having the HbA1c more than 7%. We see a lot of the people in our regular OP with the HbA1c of 11, 12, 14, 15 also, because of the very high blood sugars and uncontrolled blood sugars. And these two trials, the CAST trial and the IDCI trials, both show that the controlled diabetes individuals in India are less than 20 or 22%. So 4 in 5 people with diabetes have an HbA1c of more than the 7%. So what will happen if you keep the blood people with the high HbA1c, and we are inviting a lot of the complications? You know that both the microvascular and the macrovascular complications are directly proportional to the HbA1c levels. So the higher the HbA1c levels, the more the chances of having the ischemic heart disease, cerebrovascular diseases, peripheral vascular diseases, diabetic nephropathy, diabetic neuropathy, diabetic retinopathy, not only these micro and macrovascular complications, but unfortunately in India, most of these diabetes with uncontrolled blood sugars will definitely end up with a lot of the infections like pneumonia, tuberculosis, etc. See, if you see the insulinization in India, you all know that the management of the type 2 diabetes is multifactorial, and the most important one is the medical nutrition therapy. So most of the diabetic individuals, we can control blood sugars very effectively with a good dietary approach and exercise and yoga and meditation. But unfortunately, most of the people with type 2 diabetes, they ignore this medical nutrition therapy, and definitely they will be on the drugs therapy. So among the drugs in diabetes, we have the two types of the drugs. One is the OHS, that is the oral hypoglycemic agents, and the second one is the insulin. We all use the OHS when the HbA1c is between 6.5 and the 9 or the 10. And once the HbA1c crosses beyond the 9 or the 10, and definitely there is a room for the basal insulin to be added for the proper control of the diabetes in diabetic population. But unfortunately, most of the Indians they don't prefer the insulin even when 10 or 11. So that is the reason only 6 million Indian patients, people with type 2 diabetes, are being managed with the insulin. Just a minute. See, that means merely very few in number that diabetics in India, they are getting the insulin therapy. So I consider that insulin is the mostly underutilized drug in our Indian patients. And delayed insulin initiation of the insulin therapy. So I told you that supposed to be used the insulin when the HbA1c is beyond the 9 or the 10. But still, most of our Indians, they prefer the OHS even when the HbA1c is beyond the 10. So that is the reason 46.7% of the patients with uncontrolled type 2 diabetes, they delay the insulin therapy. So what will happen when they delay the insulin therapy? So they will be living with a high HbA1c for a prolonged period, and definitely we invite, definitely they will land up with both the micro and the macroscopic complications with the high A1Cs in these individuals. See, what are the barriers to the insulin initiation? There are some patient barriers and some physician barriers. Maybe most of the people know the common barriers here are the needle phobia. So they fear about the injections and the change in the lifestyle, the myths and the conceptions. They thought that once on insulin, lifelong insulin, or once on insulin, that means that is we are at the end of the story, or at the last days of the diabetic life only we should take the insulin. So there are the several misconceptions and the myths about the insulin therapy are there. And lack of the time when as a physician point of view, so to spare with the patient, so not being educated properly about the insulin. So these are all the different barriers for the insulin initiation in our Indian diabetic individuals. And if you know that the basal insulin alone is the most convenient insulin treatment, so you have the different insulins in our armamentarium. We have the regular insulins, we have the mistars, we have the long-acting insulins, and also we have the basal insulins or the fast-acting insulins. See, the basal insulins, we have the two types of the basal insulins. One is the insulatard, and the second one is the analogs. So these analogs, again you have the three types of the analogs in the basal insulins. One is the glargine, detemir, and the deglutide. So we will see which type of the basal insulin, analog insulin is the preferable for most of our individuals. If you see the first generation basal insulins, you have the glargine. So the glargine was entered into the market in 2013, and you have the Lantus, brand name is the Lantus, and the Basaglar or Basilar or the Nobligar. So here the half-life is about 12 hours, and administration usually the OD, and some people you have to give the BD doses also. And the detemir, and in India we prefer mostly the glargine when compared to the detemir. See, some deficiencies of the first generation basal analogs, especially with your glargine, is not truly once a daily, because it acts for about 18 to 20 hours. So sometimes we give the twice a day, and higher variability. So this is the glycemic variability. So the higher variability is there with this glargine. and fixed time dosing. So if you are supposed to start the insulin, glargine insulin at 8 p.m. and every day he is supposed to take it at 8 p.m. only. Not truly the peakless, and most of these basal insulins are the peakless insulins. So that is the reason the chances of hypoglycemia are very, very less. And higher nocturnal hypoglycemia with glargine, I don't think that nocturnal hypoglycemia is also not very high with the glargine when compared to the other insulins. So now move on to the second generation. So there is the ultra long acting basal insulin. So this half-life is nearly the 24 hours and administration is truly once a day. So here you have the deglutec 2013, and now the 300 units glargine is also available. The beauty of this deglutec is truly once a day. It acts beyond the 36 hours. So these are the advantages. So onset of the action with the deglutec is just half an hour to 1.5 hours, and the duration of the action is more than 36 hours. When compared to the glargine, so onset of the action of the glargine is 2 to 4 hours, and the duration is, as I told you, that it's about 20 to 22 hours. So deglutec has a faster onset of the action when compared to the glargine 100 units, and also the prolonged duration of the action. And this is a very important dose time flexibility. So most of these people, when you start using the glargine, so the fixed time dosing, because it acts for about 20 to 22 hours. So definitely we have to take it at a regular time. But whereas the deglutec, which acts for about for 36 to 40 hours, there is a flexibility in timing of the deglutec. So today you can take it at 8 p.m. and tomorrow you can take it at the 10 p.m. and day after tomorrow even at the 12 night also. So nothing will happen because of the high duration of the action of this deglutec. So the better flexibility with the deglutec is seen when compared to the glargine. This is a very, very important point. This is the glycemic variability. See, earlier in the diabetes treatment, we aimed for the glycemic triad. So the triad means control your fasting blood sugar, postprandial blood sugar, and HbA1c. Now we are aiming for the glycemic pentad. So pentad means two more things to your triad of your fasting, postprandial, HbA1c. And the fourth point is the glycemic variability, and fifth one is the quality of the life. So the glycemic variability is very, very important, because we have to keep the blood sugars under the target range throughout the day and the night. Otherwise, it will increase the HbA1c, and more the HbA1c, definitely the more the complications. So now, if you compare the glargine and the deglutec, the time interval, so first 6 hours and the next 6 hours and 12 to 18 hours, and then the last 18 to 24 hours. And if you see the concentration of this drug is at the same level. So that shows that the glycemic variability is very, very, very minimal with the deglutec when compared to the glargine. If you see on the right side, the glargine molecule, so the first 6 hours is about the 31%, and in the next 6 hours 29, 24, etc. So definitely it shows a low glycemic, high glycemic variability is there with this glargine. So the lower within the day variability and better round the clock coverage with the deglutec definitely scores for the glargine. So as far as the glycemic variability is concerned. So once the glycemic variability is at a lower level, and obviously the quality of the life also will be improved. So the day-to-day glycemic variability is the lower with the deglutec when compared to the glargine. And this is the continuous glucose monitoring based evidence, and here the superiority of the deglutec over the glargine confirmed on the TIR. TIR means time in range. So this is also very important. So the time in range. See here, the estimated treatment difference is a significant 1.43%. or 20.6 minutes per day in favor of the deglutec when compared to the glargine. So the time in range is also important along with the glycemic variability in the management of the type 2 diabetes nowadays. So the proven the hypoglycemic benefits, if you see these 4 trials like the begin, switch to, devote and begin. So if you see the overall hypoglycemia risk is reduced by about 28%, 30%, 60%, and severe hypoglycemia reduced by 86%, 46%, 40%, etc. So more in favor of the deglutide when compared to the glargine. So the chances of having the life-threatening hypoglycemia is also very, very low with the deglutide. So onset is a fast onset because it acts within half an hour. And longer duration of the action, the deglutide acts beyond the 36 hours. And variability, the lower glycemic variability, so that keeps the HbA1c on target. And higher the time in range, so that means the blood sugar, there won't be any chronic hypoglycemia or the hyperglycemia when you maintain the time in range drugs. So time to leave behind the first generation basal insulin because of these properties. And when compared to the glargine U300 with the deglutide, see the deglutide onset of the action half an hour to 1.5 hours, and the duration of the action is beyond 40 hours. And whereas the glargine 300 units, this is also available right now in the market, onset of the action is 2 to 6 hours, and the duration of the action is 30 to 36 hours. So the deglutide has a faster onset of the action and also the prolonged duration of the action. And flexibility in the timing, the deglutide flexibility of 8 to 40 hours, whereas the glargine plus or minus the 3 hours. So the flexibility will be higher with the deglutide when compared to the U300 glargine. In the same way, within the day glycemic variability, so this is also lower the glycemic variability with the deglutide when compared to the glargine 300. And the day-to-day glycemic variability, the lower with the deglutide when compared to the 300 units glargine. In the same way, the hypoglycemia, this is the confirmed study, shows that 30% lower rates of the hypoglycemia with the deglutide versus the glargine U300. So the deglutide has shown a significantly lower risk of the hypoglycemia. And deglutide is a more potent when compared to the U300, and if you see that it has a 30% lower potency versus the deglutide. So the deglutide is more potent than the U300 glargine. And this is our Indian study say that the glargine U300 requires 20% extra dose. So this is the Research Society for the Study of Diabetes in India 2022 clinical practice recommendations for the management of type 2 diabetes. So the deglutide is approved for use in the pregnancy. We can use it earlier. During the pregnancy, we used to use only the detimer. Now the Lantus is approved for. In the same way, the deglutide is also approved. Pediatric, we can use the deglutide. Adults, elderly, and both the renal and the hepatic impairment, we can use the deglutide. So the deglutide can be used in a wide range of the population. Almost all the population with the diabetes, whether the type 1 diabetes or type 2 diabetes, we can use the deglutide. And if you compare this deglutide with the U300 glargine, so the action is a faster onset, longer duration, lower glycemic variability, and proven safety profiles, and also the lower risk of the hypoglycemias. So this is an ideal OD basal insulin because of the flat, it's a peakless activity, minimizes the risk of the hypoglycemic event, and the longer duration of the action, and minimal variability and time in range, and with no hypoglycemia. So despite this breakthrough in the insulins, the unmet needs are the linger. So these are them. So the daily pricks. So even today, so most of the chronic diabetics, they behave like the type 1 diabetes. So the type 2 diabetes of nearly 30 years or 40 years or 50 years duration, they almost behave like the type 1 diabetes. There we need a lot of the injections, mostly the basal bolus drug therapy is needed in such individuals because of the more and more pricks and delayed insulin initiation and the needle phobia. So is the frequency of the injections a burden to your patients? And definitely patients and the physicians identify higher frequency of the injections as a burden. More than the 90% wish for the good control of the insulin not injected by every day. Do your patients have the difficulty with administering insulin injections daily? So most of our rural Indian population, so they feel difficulty in administering insulin. Now, with thanks to our insulin pens, which are supplying at free of the cost for most of our diabetic individuals. So now the 59% of the physicians report it is very difficult or somewhat difficult for the patients with diabetes to administer the daily injections. I think this percentage is coming down because of our regular follow-up with our patients. Do your patients take insulins at the prescribed times daily? Yes. Adhering to the strict insulin injection timing is very, very challenging in our patients. So they say that the difficulty or somewhat the difficult for their patients with diabetes to take the insulin prescribed time or with the meals every day. So whenever you prescribe the prandial insulin, especially your Fiasp, etc. So they are supposed to take just before the food, or when you are giving the atropine or the mixtures, they are supposed to wait for about 30 to 40 minutes between the injection and the food intake, because it takes time for about 30 minutes for the atropine and the mixture converting to the more therapeutic levels. So are your patients on insulin adherent to these therapies? So 65% of the patients are non-adherent. So definitely we can reduce this poor adherence by our continuous educating the patients. See, these are all the consequences of the repeated injections. Unfortunately, we are not seeing this type of the lipohypertrophy, lipoatrophy nowadays. But still the burden of the daily injections, needle phobia, delayed its initiation, these are all playing a major role for our poor glycemic control. So the solutions towards the better glycemic control, less frequent injections, so preferably once a day, more welcome. Simple and easy to use the regimen and flexibility in the dosing, these are all good things for the people of the type 2 diabetes to adherence, to improve their adherence, to improve their convenience and their satisfaction, and finally we can achieve our blood sugar targets around 100 and 150 or 6.5 of HbA1c. So the future is bright. Now big thanks to our Banting, is an orthopedic surgeon and the best medical student who invented one of the best molecules in our clinical medicine, that is the insulin, in 1921, and they got the Nobel Prize for that. And the animal insulin preparations were given earlier, the porcine and the bovine, and then we have the human insulins, but the recombinant E. coli, and then we have the rapid acting analogs, biphasic analogs, etc. Now in the future, near future, we are going to get the once weekly injections, and which are having the weight neutral and the hypoglycemia of benefits. And oral insulins are in the pipeline, glucose and thank you very much for your patient hearing, and if you have any queries, I will be very happy to answer them.
Thank you, sir. Thank you so much for making the topic simple and quick. Sir, there are few questions. Your permission?
No, fine, definitely.
Sir, since when you most of your patients when we want to initiate our insulin therapy, this is some extreme upgrade. So how do you ensure patients adherence to insulin therapy?
See, we have to explain to the patient that all the advantages of the insulin therapy and the disadvantages of the hyperglycemia. See, if left untreated with the insulin at the right time, and definitely these people will go into the lot of the complications, and these complications sometimes life-threatening complications like acute myocardial infarction or CVA or initiation of the CKD. So these are very, very bothersome and complications. So if you tell to the patient that this is the right time to initiate the insulin, and definitely they will listen to us. And one more thing is, and the insulin, physician should talk about the insulin not after 5 years or the 10 years of the diabetic life. Even on the day of the diagnosis of the diabetes, one should utter few words about the insulin, so that these people will follow us whenever we say that insulin is needed for them. Because insulin is one of the important molecule to control the high blood sugars. Even sometimes nowadays we are using the insulin even on the day of their diagnosis, provided if they present with the very high blood sugars and with the symptoms. See, sometimes the people presents with the fasting blood sugar 300, postprandial blood sugar 450, with polyuria, polydipsia, polyphasia, etc., and also unintentional weight loss. And definitely, even though the patient is 40 years or 50 years or 60 years, when the patient is very symptomatic, and definitely we are supposed to start insulin, even though when the urine ketone values are the negative. See, all symptomatic individuals with type 2 diabetes, who should initiate on the insulin? Definitely there are a lot of indications to use the insulin in type 2 diabetes, especially the perioperative period. the gestational diabetes, or the patients are admitted in the ICUs, are admitted with the sepsis, or when the patient is infected with very sputum positive pulmonary tuberculosis. So definitely these are all some of the indications where we are supposed to use the insulin, even though the diagnosis is the type 2 diabetes, where OHS can be used as an initial agent. So these are the very, very important. So the treating physician or a diabetologist should have a very good knowledge about the insulin and insulin usage and all the advantages and the disadvantages of the insulin. So definitely the people will listen to your words, and it is very easy to start with these basal insulins. So you can start with the 10 units or the 15 units, maximum 10 or 15 units of the basal insulin, and then you can titrate with the fasting blood sugars. So today you start with the 10 units, and once in 3 days or once in 5 days get the fasting blood sugar. When the fasting blood sugar is much higher, above your target level, so definitely you can increase the basal insulin dosages till you achieve the normal fasting blood sugar. And if you get the hypoglycemia range, say fasting blood sugar is 80 or 85 or 60 or 70, so definitely you can reduce the doses of the basal insulin. So it's very easy to initiate the basal insulin, and it is very easy to titrate the dose also.
Thank you, sir. Thank you so much. Sir, what are your thoughts on using time and range as a better parameter to analyze two glycemic?
Please repeat the question.
What are your thoughts on using time and range
Yes, time and range.
as
See,
a parameter?
yeah, this is the very this is the very important timing range. Otherwise, when the timing range is out of the timing range, definitely the people will be in both the hypoglycemia as well as the hyperglycemia, mostly the hyperglycemia. And once the patient is in the hyperglycemia, so we are inviting more and more endothelial dysfunction. So this endothelial dysfunction definitely will aggravate the atherosclerosis, and we invite the complications, especially the vascular complications. So you all know that the most common complication of the type 2 diabetes, the cause of the death in Indian patients is the myocardial infarction or a major vascular event. So when we won't control when we won't keep the blood sugars in the timing range, and definitely we are inviting more and more endothelial dysfunction and premature atherosclerosis and the vascular events.
Thank you. Sir, how to move from the sliding scale system to basal bolus specific to smaller?
See, the sliding scale is outdated. In the sliding scale, we are reactive. See, when the blood sugar is 250, we are giving the 10 units or the 5 or 6 units. When the blood sugar is 300, you are giving about 12 units or the 14 units. When the blood sugar is 100, you don't give the injections or insulin. So this is the reactive. See, what is good is proactive approach. So you should see that the patient should not, the individual should not say that patient diabetes is an individual. So the gentleman, the individual should not have his blood sugars beyond 180. So our target should be between 140 to 180. So once the blood sugar is more than the 180, and definitely we are inviting the complications, especially the inpatients, especially the patients in the ICUs or in the wards. So our goal is to keep the blood sugars between 140 to 180. So always the proactive approach is more important. So this is the very easy to initiate on the basal bolus therapy. So the basal bolus therapy means we have to give the 3 regular insulins. So whether the pre-ASP, we use the pre-ASP. So 1 shot before the breakfast, 1 shot before the lunch, 1 shot before the dinner, and 1 basal insulin of your deglutec at after bedtime, maybe the 10 p.m. And you see, and also you have to get the 4 blood sugar values every day. One is fasting, the second one is before the lunch, and the third one is before the dinner, and the fourth one is before the bedtime and during the bedtime. So you have to adjust these doses of the basal bolus therapy according to these 4 values. I told you the basal insulin has to be adjusted to according to the fasting blood sugar. In the same way, in the pre-breakfast, we give the regular insulin, and that dose has to be adjusted according to your pre-lunch blood sugars. So if the pre-lunch blood sugar is 200, and you have to increase the pre-breakfast regular insulin. In the same way, the pre-dinner blood sugars will tell you the dose of the pre-lunch regular insulin. So in the same way, the bedtime blood sugar levels will guide you about the dosage of the pre-dinner regular insulins. So the pre-breakfast regular, pre-lunch regular, pre-dinner regular blood sugar the insulins depends on the pre-lunch, pre-dinner and the pre-bedtime blood sugars. And the fasting blood sugars, and you have to adjust about the basal insulin. That's how you have to give the basal bolus therapies.
Thank you, sir. Thank you so much. Sir, what is your opinion on the quality of life in patients and your basal health? Shall I minimal risk of life?
See, this is the very important the quality of the life. I told you glycemic pentat nowadays. So we have to aim for the fasting, postprandial, HbA1c, and also the glycemic variability, time in range, and then finally the quality of the life. So the quality of the life will be good provided if the patient is not getting any hypoglycemia. Not only the hypoglycemia, you should not get the hyperglycemia also. So hyperglycemia, more and more hyperglycemia, more and more endothelial dysfunction. In the same way, when the patient is having the hypoglycemia, so hypoglycemia is of two types. One is adrenergic hypoglycemia, the second one is neuroglycopenic hypoglycemia. So these hypoglycemias, the patients will have a froth in the mouth, some unconsciousness, and sometimes convulsions, and finally the death also. So the hypoglycemia, the severe hypoglycemia is very, very near to the death, and we should not allow our diabetics to get the hypoglycemic attacks. So the quality of the life is very, very good with these basal insulins, with these analog basal insulins, because they are the pre-class insulins with no hypoglycemia.
Thank you, sir. Thank you so much. Sir, since you said that hypoglycemia and hyperglycemia, so there is a question, sir, in the hospital setting, both hyperglycemia and hypoglycemia are associated with adverse outcomes.
Yes.
How do we recognize and manage hypoglycemia, especially in hospital?
See, in the hospital settings, it is very easy to identify because we ask the sister to get the blood sugars very frequently. At least we get about 5 to 6 values of the blood sugars every day, and definitely we can know that whether the patient, whether the person is getting the hypoglycemia or the hyperglycemia. When he is getting the hypoglycemia, we have to reduce the regular insulin just before that hypoglycemic events. And when the patient is having the hyperglycemia, we have to increase the doses of these insulin therapy. And provided if the patient is taking the meals and when the renal function is the good, and definitely we can add few OHs which won't cause the hypoglycemia also, like metformin or your dapagliflozin or your gliptins. So these drugs won't cause hypoglycemia, and they can be included along with this insulin therapy, provided if the patient is not in the shock or not in the hypoxic conditions. So definitely when the patient is symptomatic or in the hypoxic conditions, we should not use the OHs. So otherwise, by the time the patient is comfortable and by the time the patient is about to discharge from the hospital, so if the renal function is the good, and definitely we can add metformin or the dapagliflozin or empagliflozin, preferably and that is SGLT inhibitors or the gliptins. Like your sitagliptin or the linagliptin or saxagliptin, etc. And plus your insulins. See, once the patient is in the hospital, preferably we give the basal bolus therapy, and by the time we discharge, it is very difficult for them to take the 4 shots a day. So then we move on to the say a basal insulin plus OHs or the mixed insulins plus the OHs, etc. So it depends on the person to the person, and when the patient is having the more and more prandial, postprandial hyperglycemia, then we prefer 1 shot or 2 shots of the regular insulins before the breakfast or the lunch. When the patient is having the more of the fasting hyperglycemia, we prefer the basal insulins.
Thank you, sir. Thank you so much. Sir, the final question. Degludec is safe to be used in special populations like renal, hepatic, and even pediatric populations. And recently we got approved in diabetes in pregnancy. Do you see really a wider applicability of this patient?
So definitely it is applicable to, it is useful for all the population. So definitely it can be useful because of these advantages when compared to the other insulins. But the only thing in Indian population is not all people can afford it. So definitely those people who can afford, and definitely this is the best choice to be used as a basal insulin.
Thank you, sir. Thank you, sir. Sir, final message to all the executives who are attending to this session.
See, one should not fear about the insulin therapy, and every diabetic they need an insulin therapy, and we should know everything about the insulins. And insulin is a very very important molecule in the management of the diabetic individuals, whether it is type 1 or the type 2 diabetes. And of course, type 1 diabetes they survive only on the insulin. In type 2 diabetes, the insulin is also required for the control of the blood sugars very effectively. So among the insulin therapies, you should know that the prandial insulins and the basal insulins, and then act accordingly.
Thank you, sir. Thank you so much for sharing your opinion.
Thank you very much for your.
With this will come to end of the session. Once again, I thank you, sir, in spite of your busy schedule accepting our invitation to this session. And I also thank all the executives who attended for this meeting. Thank you, sir. With this will come to end of the session, sir. In coming months, we'll come with your topic.
Thank you, thank you.
Thank you, sir.
Thank you, thank you.
Sir, with your permission, we will end this.
Okay, thank you.
Yeah. Thank you.
See, the insulin is a very very important drug to be used for all the diabetic individuals. So in fact, no, it is a drug of choice for the type 1 diabetes, and even for the type 2 diabetes for the proper control of the diabetes. See, a lot of the people with the diabetic foot ulcers, or diabetic infections, or carbuncles, or skin and soft tissue infections, or severe urinary tract infections like ascending pyelonephritis, or in cholecystitis, or abdominal infections, or in meningitis, or in pulmonary tuberculosis, or Bart's pain. So definitely they need insulin therapy. So one should not fear about the insulin, and definitely we can control the blood sugars very effectively with the insulin. And the advantage of insulin is, as it is an anabolic hormone, the appetite also will be increased with insulin therapy, and they gain the weight, and they conquer the disease very fast, because insulin also acts as an anti-inflammatory agent.